Good afternoon, everybody. My name's Angie Bexley. I'm from the ANU and I'm your chair for this session. Welcome also online. We have one speaker online and hopefully an audience online. We can't see you yet, but I'm going to try and navigate the app. So really lovely session this afternoon, Understanding and Addressing Health Inequalities. We have three presentations. The first, Carolyn Van Gamet, I hope I'm pronouncing that correctly, Senior Research Fellow at Burnet Institute, presenting together with Wendy Williams, Surveillance Officer from Vanuatu's Ministry of Health. Welcome. And they'll be presenting on supporting the development of Vanuatu health research agenda through collaboration. So picking up, I think, a lot on what we've been talking about the last couple of days. Secondly, we have Leah Burns. Welcome, Leah. PhD student, Deakin University, presenting on understanding social change to navigate an evolving development landscape, insights from girls in northern Vietnam. That will be great for a gender perspective. Welcome. And lastly, we have Badrul Hook from the Fred Hollows Foundation joining us online and presenting on navigating comprehensive eye care with disability and lessons from Bangladesh. So very short, I'll hand over to you, Caroline and Wendy, to kick us off.
All right. Oh, there's the screen. I won't be able to see that. We'll just make it up. Hi, good afternoon, everyone, and thank you for coming today. So yes, my name's Caroline and this is Wendy. So we'll be presenting on a process that we undertook last year in Vanuatu to develop the Vanuatu Health Research Agenda. So just for background, the Burnet... Oh, the microphone, sorry. Yes. So the Burnet Institute, in case you're not aware, is both a research institute and a government-accredited NGO as well. So we're both accredited with the National Health and Medical Research Council as well as ACFID. So DFAT, sorry. So yeah, we're at that nexus between research and development. I'll press this one. Cool. So I'd just like to acknowledge the Boonwurrung people of the Kulin Nation, where the offices for Burnet are located in Melbourne. And we pay our respects to elders past and present and extend that respect to all First Nations people, including we've got offices for the Burnet in Papua New Guinea, Myanmar, and as of 2 weeks ago in Vanuatu as well. So extend our respect to leaders in Vanuatu, PNG and Myanmar too.
Okay, so for today's session, just a brief overview of what we will be speaking about. So it's about, the first one is on the background of the health research agenda, and then moving on to how Vanuatu has initiated the process of developing the agenda, the methods we've used, the key results, and the next steps of the process.
Okay, so we'll just start off with describing what a health research agenda is. So low and middle income countries are often faced with a diverse range of donor-driven research agendas, and this is really clear in, across the world that researchers from high income countries come in with their research questions and their priorities. But the impact of this is that it weakens national health priorities and national research priorities. So a health research agenda, it's a strategic document that can be used by countries to identify what knowledge gaps exist and what the priority areas for health research for local and international researchers are. So priority setting activities can help to direct use of finite resources to support research that maximises public health impact and drives health equity. So we know that particularly in Pacific Island countries, there's a really small health workforce. So people who are in one role often have the hats of 10 people. So you have to make sure that if people are involved in research or other activities, that it's actually benefiting them, not just the researcher with their research questions.
Okay, so moving on to the process that the Ministry of Health has requested Burnet. So in 2024, the Vanuatu Ministry of Health took the initiative to develop its first health research agenda. So the approach we took is we approached the Burnet Institute for the technical support. And followed that, the agenda was specifically based on 3 key objectives. And one is to ensure there's alignment with the Vanuatu Health strategy, the Vanuatu Health Sector Strategy Plan, which is from 2021 to 2030. And the other one is to focus on guidance into resource allocation. And the third one is focus on coordination of international and domestic research efforts.
So in terms of frameworks for research prioritisation processes, there's many different approaches to developing these that exist, but there's no agreement what might constitute best practice. So we use an approach that was defined by Virga et al., and it proposed a checklist for what research priority setting approaches should include in the overall process. And we first used the Virga the checklist back in 2016 when Burnet supported the PNG government to develop their HIV research agenda. So for the checklist, for preparation, is to make sure that you have a good understanding of the context, existing research that's happened, the approach or the methods for consultation, and then for narrowing down to the actual prioritised list, making sure that you're inclusive, making sure you include all relevant stakeholders to the agenda, depending if it's a broad research agenda or it's a narrow focus. Gathering information and looking to see what existing data or resources already exist, and also thinking ahead and planning for implementation and how the research agenda will be used. During the consultation process, there's a process for defining and discussing with participants and stakeholders about what criteria should be used for deciding which priorities, research priorities to include and what the methods are. And then after the priorities are set, how to evaluate the research agenda, and also making sure that it's as transparent as possible.
So the consultation process that we've undertook for the development of Vanuatu Health Research Agenda, there's 3 stages. And stage 1 is focused on brainstorming what the research gaps are. And from that, we use the 4D framework to describe the research topics that were identified. And in stage 1 as well, we've also did a survey as well to confirm what the values and the criteria are. So how the research topics were designed will be focused mainly on the values that were identified, and the scoring will be focused on the criteria that were determined by the participants. In stage 2, it focuses on scoring the research topics that were identified, and that is based on the criteria from stage 1. And then we proceed on to analyzing the research prioritization scores, and then finally the final stage, which is stage 3, and that is more focused in consultation to determine how to present the results, and also that contributes to the final research agenda itself.
So we use something called the 4Ds framework, which is very much used in the health research space. And I don't know how transferable it is to other areas, but the 4Ds are essentially description, delivery, development, and discovery. And this is used because all health research topics can fall into one of these four boxes. So description is research topics that describe the magnitude of a health problem. So it's all about description. Delivery is all about using existing health resources and how to best deliver these health resources or interventions. Development is research that's focused on improving health interventions that already exist but could be made more effective, affordable or sustainable. And discovery is about new interventions and new ways of doing things. And it includes all research questions that would lead to innovation and entirely new health interventions. So for moving on to the research
domains. So we have topics that were identified in stage 1 were focused mainly, were grouped against 4 different domains, and that is reproductive, maternal child health, communicable diseases, healthy lifestyle, and health systems. And each of these domains reflects the key health challenges and opportunities that are currently in Vanuatu.
So for stage 1, we used, in the consultation process, we used a series of worksheets to help guide the identification and the listing of research topics. So working in groups, people filled out the second column for each health problem, and it was a series, like a logical series of questions to help identify whether it was description, delivery, development, or the final D, which was discovery, about what the research gap was, and to really clearly articulate what the particular research gap and what was needed to move on to the next stage. No, that's fine, it's the same. Do you mean the third column? Oh, it says health problem. So there's 3, so the first, can you say, do you want me to read through the questions? So the first, it's, do we know the burden, incidence or prevalence of the health problem? Then, do we know the causes or determinants? Are there solutions available for this health problem? Do we know if existing solutions are working? And do we know how existing solutions can be improved? So that guides you through the 4 Ds. And then the 3 columns is actually one for each health topic for that work, for the group working on it, and they could use multiple sheets. Yeah, so just a matrix to help work through that.
So after the research, so after the research gap that were identified in worksheet 1, the teams worked together to fully describe the research topic, and that was needed. And teams outlined reasons to why the research was needed, looking at the type of research that is needed using the 4D framework, and then looking at which specific population or considerations for where the research should be targeted. And that is another worksheet that is being filled up based on the topics that were identified.
And then finally, in stage 1, there was a process to determine what the criteria would be that were used to score each of the research topics. So the process that we used for this is that a full list of different criteria was provided to participants, and then essentially participants then they completed an online survey to say which of the criteria are important to them, and then using quantitative analysis we could determine what the top, like the ranked criteria were, and then deciding as a group to determine which are the final number of criteria to be used in the voting process, recognising that you can't have too many criteria because each research topic needs to be scored against the criteria. So 4 was a reasonable number, 10 would be unwieldy, for example.
So after we completed stage 1, we proceeded on to stage 2, which is on the voting stage. And we have a total of 15 participants who voted against all the 102 topics, research topics that were identified. And it was against all the 4 criteria that was mentioned by Caroline. And the scoring was done using an online platform, online tool, and that is called the Red Cup. And 14 participants were selected by the Vanuatu Ministry of Health, and the weighted and unweighted research priority scores were calculated for each research topics that were listed. And following that, the score research topics were then ranked using the weighted research priority scores. At the end, if a research topic that ends up with a higher RPS, that's indicated that it's a higher priority for the Vanuatu Ministry of Health, and therefore that is included as the top research topic for the agenda.
Okay, and so stage 3 is about pulling it all together and deciding how to best present this in the final document. So the 102 questions were then ranked from 1 to 102. And so then we've done extensive consultation with the Ministry of Health to figure out how we can use it. The first iteration was actually having the list of questions by health domain. So for example, all the communicable diseases questions listed according to rank, as well as their overall rank within the full list of 102 questions. They're ranked within the communicable diseases domain, as well as their research prioritisation score. This was found to be really unhelpful and led to competitions between units. So we rethought that, and so the final decision is that we will present, still according to the research domains, but by health topic, and just limiting to the top 5 research topics. The full list will still be included in the appendix, so people can refer to that. But the aim of this is to make sure that it's as useful in determining what the main questions that are of priority to the units are. So we've got questions here by communicable diseases. Let's go through them. Reproductive, maternal and child health. So we've got reproductive, maternal and child health, immunisation and vaccine preventable diseases. Then by healthy lives, sorry Wendy, you go. Okay, you can do the last one. So we've got mental health and neurological conditions, nutrition, NCDs or non-communicable diseases, antimicrobial resistance, environmental health and One Health. And finally for health systems, this included health systems, health workforce, health information systems, and health equity in vulnerable groups.
And finally, for the reflections on the process that we've conducted, what worked well is that the project working group includes members from both the Vanuatu Ministry of Health and the Burnet Institute, and they've both collaborate in partnership to co-facilitate the stage 1 consultation process. And there's also multiple opportunities and avenues that people have used to submit their ideas on the research topics itself. And it's also aligned with the Vanuatu Health Sector Strategy, and also that's towards the Vanuatu Health Research Symposium that we've conducted, and also the Vanuatu Health Research Ethics Committee, especially with a review of health research that are being submitted to be conducted in Vanuatu. And follow through to the next step. So currently the final, we are currently reviewing the final research topics, and that is by the teams with the Vanuatu Ministry of Health. And after that, we're hoping to submit a report to the Vanuatu Ministry of Health Executive for the endorsement, and follow through that the launch of the health research agenda itself with the upcoming health research symposium, which is in September. And we also anticipate to share this methodology further with other countries so that they can replicate if desired. Thank you.
And that brings us to the end. And I think we're doing discussion after. Is that nice? Cool. Cool. Yeah, right. Thank you.
Thank you, that was fantastic, and I love the practical nature of that. So how do you embed participation and inclusion in each of those steps without making it unwieldy? Really interesting insights. Next up we have Leah Burns, who's going to talk to us about her insights from her PhD work from girls in northern Vietnam. Take it away, Leah. About 20 minutes.
Thanks, everybody. Oh, am I close enough? Okay, here we go. So today I've been asked to share some reflections and musings from my fieldwork that I undertook last year as part of my PhD work. But firstly, before I do that, I just want to position myself because I have two hats. Okay, my background is many years with AusAid, also with the Burnet Institute in Myanmar, and then more recently with Child Fund Vietnam. So moving across the development and the research space, and now I've just taken a study sabbatical to do some new training, and really want to, in the future, work much more at that connection between research and development and bring all those skills together. So that's where I'm sitting on these musings, because I've got my two hats going on all of the time here. Okay, so my PhD work is on the influence of social norms on sexual and reproductive health for adolescent girls, particularly looking at ethnic minority girls in northern Vietnam. I did 3 studies, 4 publications, and what I'm going to share with you today is some reflections on my in-depth interviews I took with the adolescent girls and their female carers. I did 2 research articles out of that. One was published just last week. Yay! Thank you. And the next one is going through that journal peer review vortex thing. Anyway, I'll move on from that. So before I start though, these are a couple of questions I have asked myself, and I just want to throw them out there to you guys to think about while I move through my sharing. So, you know, we know there's a lot of work going on around strength-based approaches in public health research, the development space. There's a little bit less of that. It's more focused on needs-based, and I think we all know that ideally we'd have a combination of both. And so I've just been thinking, you know, do we understand the inherent strengths of adolescent girls and how these might differ across contexts and be specific to cultural factors active at the time in their community? There's a lot of social change going on in communities and it's moving quickly. And of course, these communities are responding to that in their own ways. And do we always understand what they are? And then the second question is how specific is the evidence base that we use for project or programming decisions? Do we use the right mix of national level and local level data? And are our needs assessments asking the right questions? I'll leave that with you for now. And I'd love to hear your views as well. So the point of all of this, I should have mentioned at the start, was to get your feedback and your ideas about this. And I'd love to learn from your experience. So I'm just giving you a little slice of what happened in the fieldwork. So this is just some background. So working in Vietnam, 100 million people in Vietnam, 41% are urban. There's 54 ethnic groups in Vietnam. The largest is the Kin or the Viet group at 86%, and then the other 14% are 53 ethnic minority groups. So I am working with the Tay group, and they are the largest ethnic minority group, but at 1.8 million people, so still not a lot. They live up in the 6 provinces up in northern Vietnam. And we were working with the Tay communities up in Cao Bang. So I don't know if you can see the green arrow up there. You can barely see it from here. Cao Bang's right up the top of northern Vietnam, bordering China. So I think they've got a 1,400 kilometre border with China. So for adolescent girls up there, there's a lot of challenges for their sexual and reproductive health. There are structural challenges to adolescent and youth-friendly health services and to the comprehensive sexuality education in the schooling system as well. It's not a priority in the schooling system or in the health system, and health promotion campaigns are very rare. There's increasing risky sexual behaviour with adolescent girls up there and the boys. It's not just the girls, it's the boys as well. A lot of unintended pregnancy and a lot of repeat abortion as well. So there's some challenges up there. And this is all happening in a very conservative social environment as well. Gender norms related to adolescent sexuality are very restrictive, and it makes it very difficult for adolescents, boys and girls, and even adults to talk about sexuality or sexual and reproductive health. So the field work, we were up in Takan district in Cao Bang for 2 weeks. We conducted interviews in 2 commune health facilities and 1 township health facility. We did qualitative interviews with 16 to 18-year-old adolescent girls and their female carers. So there was a total of 40 interviews, and we did them with dyad pairs as well. So it was adolescent girls and their mostly mothers from the same household. We did separate face-to-face interviews. We asked things about socio-demographic factors, perspectives and experiences of gender roles, intergenerational communication, social expectations and questions about sexual and reproductive health. We didn't ask about strengths or needs. It was just about experience and perspectives on their experience around sexual and reproductive health. The inclusion criteria for the participants was fluency in Vietnamese. Logistically and from a time perspective, it would have been too difficult to conduct interviews in Thai language. But what we found out when we started interviews was that most of the adolescent girls didn't speak the Thai language anyway. So, and I've subsequently realised, and wow, I should have looked at this at the start, is that Thai is now an endangered language in Vietnam. So many of the Thai parents speaking Thai to each other, but they are not passing their language on to their children. And of course, the children attend school and they are taught in Vietnamese as well. Interviews were conducted in Vietnamese and then translated into English to me and backwards and forwards. We ended up getting it down to quite a nice flow actually at first. I was really stressed about it at the start, thinking this is going to be weird, it's going to be messy, but in the end we got the technique down right, and it didn't appear that our participants were too bothered by it actually, so that was great. So some messages out of all of that. So firstly, the girls and their female carers, for the participants, the most important messages were around premarital sex and unwanted pregnancy and the repercussions of that. So the girls' sexual development was centred around avoiding premarital sex, avoiding pregnancy, and to protecting the reputation of their family. And those words were used a lot by the participants. The mums were expecting the girls to protect themselves and their families. So that's a lot of responsibility for young girls. But at the same time, the adolescent girls were telling us that they were having sex before marriage. You know, a lot of the girls said, if you have a boyfriend or if you have a girlfriend, you're having sex. That's it. Just very normal. Everyone's doing it. Like, okay. So sexual and reproductive health topics were considered sensitive and personal. So the interpersonal communication between women, their families, and across generations was difficult, and it just wasn't acceptable either. It was considered taboo, or even the word evil was used a few times. Gossip was of great concern, also inhibiting girls from sharing with their friends and their mothers in case their stories ended up at the marketplace as local gossip. And so the interpersonal trust on these topics was quite low. Accessing reliable sexual and reproductive health information and education was difficult. So as I explained, school-based sexuality education was practically non-existent or just centred around not having premarital sex and avoiding pregnancy. So the socially conservative mindset was also very clearly coming through from the teaching in the schools. Adolescent girls did not visit the health clinic for sexual and reproductive health services or support. The clinics were too far away or they were too close. The health worker knew my mum, or I knew the health worker would gossip about me. So these are some really interesting barriers. So the female carers, they understood that their daughters needed the information to protect themselves. They thought that there was enough information around. My daughter goes to school, she's getting information, and if she's not, well then she can just get online and get it. So that's very much where the mothers were sitting around how their daughters would be informed. But there was little understanding by the mothers of the potential risks of that around misinformation, disinformation, and exposure to unsavoury content or exploitative content. Overall, health and digital literacy is very low up in these areas. Next few messages were around the social expectations from mums and society related to the sexual and reproductive health of adolescent girls. And they're shared consistently across generations, and they are very gendered. All the messages about premarital sex and avoiding pregnancy were for the girls, and the social and familial expectation that girls will finish school and they'll get married. But for the boys, the flow of parental advice was very different, and I think you can see that from the top quote up here, mum saying to her daughter, no sex, don't get pregnant, but to the boy, don't drink or smoke too much. Yeah, it's okay. So this generation of adolescent girls are beginning to question these social expectations. that are placed on them. They're becoming sexually active earlier. They said boys should be responsible too. It's just not all our fault or our problem. And they understood the sensitivity around discussing these topics and seeking information about these topics, but they didn't understand why. And they said, we want to talk more to our mums about this. We want to share information and learn. So this generation of adolescent girls are becoming curious about their sexuality, they're having sex, they're questioning the urgency and reasons for marrying. And so for this generation of girls, something is shifting. Social expectations, their normative behaviour is starting to shift. It's very different to how their mothers behaved and how they undertook themselves and went through their sexual development. So just some little reflections that were going through my mind during my field work and subsequent data analysis. So there's a lot of conservative expectations of adolescent girls, and they are considered protective and passed on intergenerationally. So mums think they're doing the right things. They're doing what their mothers did. They're passing on the same messages that their mothers told them, but in fact they're harmful in many ways that didn't appear that everybody was fully clear about the potential harms. So for this generation of adolescent girls, they're exploring their sexuality and premarital sex is becoming more common. But girls are dissatisfied with the school and community-based information that they have access to, and they're actively seeking sexual and reproductive health information on the internet. And they are encouraged to use online resources, but they are unsupported. So adolescent girls are accessing the internet, they're being exposed to a lot of conflicting sexual and reproductive health information from a diverse range of resources or sources, and there's a rapid and increasing reliance on online resources given there's not very many or any public or even private or even NGO or donor programs in these areas. So we're seeing changing sexual behaviours and information-seeking behaviours which are all introducing new risks. So my reflections. So in this community, there's rapidly shifting normative scenarios for adolescent sexual and reproductive health. This is the first generation where girls are starting to question what is expected of them and their behaviours are changing accordingly. I got a real sense of determination and empowerment from the girls. You know they need information, they know which resources weren't suitable, and where another option was available to them, but they're doing it in isolation, so the girls are really doing it for themselves up there at the moment. And they're showing agency and determination to look after themselves. And I just was reflecting, this is such there's this organic momentum of change. The girls wanted to know more, they wanted to help each other, they wanted to be engaged in community health promotion events. They really wanted to get active, they wanted to participate, but there's no opportunity for that. So I just thought, wow, what I felt I wanted to do was to wrap up the interviews and go straight into a co-design process with them. That was the momentum there. They were just desperate for it and really interested to engage on what support they needed and how they would like it to happen as well. So I was just reflecting to myself, how do we connect into and harness this agency and determination when it starts to just organically shift in a community, and do we consider those things enough in the work that we do? Thank you. Oh, lots more questions, but okay, I've run out of time. Anyway, thank you. Thank you. Thanks.
Thanks so much, Leah. It's so great to hear the story of often the missing middle of the adolescent girls. So that was fantastic. So much to think about. In your provoking question, what do we think about as strengths? And I was like, what does the development world think about as strengths? Like they are seen as risk normally. And to hear those stories of agency empowerment is a fantastic opportunity for development intervention. All right, next up we have our online speaker, Badrul Hook from the Fred Hollows Foundation, talking to us about navigating comprehensive eye care with disability lessons from Bangladesh. So take it away, Badrul. I'll keep a timer and come in if you're going over time, because you can't see me from where I'm sitting. So over to you, Badrul. Thank you.
Thank you. Hi, hello everyone. I'm joining from Bangladesh, so it is morning. So good morning from Bangladesh, and I think it is afternoon there in the panel. So good afternoon to all. I'm Ekim Badrul Haq, and I work as a program manager at the Fred Hollows Foundation Bangladesh Country Office. It is truly a pleasure to be here with you all. I would like to take this opportunity to share some key aspects of a project currently being implemented in Borishal Division of Bangladesh. And it is not a research findings, but we have CAP and midterm evaluations. So the information I will share today, these are extracted from those reports. I hope the disability context and experience I share today will resonate with you and perhaps influence your own thinkings and perspectives. Next slide, please. To begin, I want to share the words of one of our project beneficiaries, words that may feel universal. Ashraf is a person with physical disability who uses a wheelchair. He lives in Jhalokati, a small district in the Borishal division of Bangladesh. He shared, I have always been a determined person, overcoming many challenges in life despite my physical disability. However, losing my vision was different. It shattered my spirit and severely affected my mental health. Following cataract surgery from the project support, Ashraf told us, I feel as though I have been given a new life. It's truly an incredible and life-changing transformation. So Ashraf's experience highlights what eye health truly means for persons with disabilities. Living with a disability already presents significant challenges, but when vision deteriorates, on top of that, it can stripe away a person's hope for life. This story reminds us that restoring sight is not just a medical intervention, it is a powerful act of restoring dignity, independence, and emotional well-being. Next slide. In Bangladesh, approximately 1% of the population is blind or visually impaired, and 50% live with some form of disability, according to WHO. Yet, persons with disabilities are systematically excluded from basic opportunities and services like education. Only 5.3% have access, only 33.8% are employed, only 62% receive essential care. Disability inclusion is critical to achieving universal health coverage and sustainable development goals in Bangladesh. It ensures enabling quality education for all with visual impairment, increasing economic participation and productivity, promoting health equity for all, fostering inclusive societies, and reducing inequalities. So universal health coverage and the SDG cannot be achieved without addressing the barriers faced by persons with disabilities. Next slide. The project component I would like to highlight is currently being implemented in Borishal division of Bangladesh through our private partners mainly. And it is a riverine and hard to reach region where communities face significant barriers in accessing essential health services. The initiative is specially designed to reach the unreached, delivering a comprehensive eye care approach that is inclusive and equitable regardless to the diversity of the background. The project focuses on key conditions, including cataract, refractive error, diabetic retinopathy, and primary eye care. Services are delivered through accessible service points, strengthen referral pathways, and community-based strategies. A core emphasis of the project is on ensuring accessibility and inclusiveness with active community involvement, particularly engaging persons with disabilities to make eye care truly available and responsive to the needs of all. Next slide. In the project, we adopted the twin-track approach to promote disability inclusion in eye health. This involved implementing both disability-specific initiatives and disability-inclusive strategies to ensure that persons with disabilities have equitable access to eye care services. Through this approach, we aim to ensure their full inclusion on an equal basis with all members of the community. By applying the twin-track model, we sought to address the unique needs of persons with disabilities through targeted intervention and embedded inclusive practices across all our eye health services, programs, and outreach activities. Next slide. To begin with, we focus on making eye care facilities more accessible for persons with disabilities. As a first step, we conducted accessibility audits in collaboration with expert organizations such as CDD or CBM Global. These audits played a crucial role in identifying the infrastructural and service level barriers, and we observed a clear increase in patients visiting following these assessments. Based on the audit recommendations, we provided initial support for accessible renovations within the facilities. Encouragingly, this created a ripple effect. Partner eye care facilities have now begun allocating their own resources to continuing improving accessibility, demonstrating the ownership and long-term commitment. In parallel, we recognized the need to address attitudinal barriers among serving providers. So our efforts began with the country team of the Federal Foundation receiving orientation on disability inclusion. We then cascaded this knowledge to our partner organizations, targeting those staffs directly involved in service delivery. Again, we partnered with CDD and CBM Global to ensure high quality training and sensitization. And as a result, service providers have become more aware and empathetic in their interactions with persons with disabilities. This shift in attitude is reducing the access barriers. Next slide, please. To promote inclusive eye health, we supported our partners in organizing community outreach programs designed with an enabling environment. These efforts include ensuring accessible venues, introducing fast-track services for persons with disabilities, engaging trained support volunteers, and providing dedicated counseling services. As a result, the visibility of persons with disabilities in outreach camps has increased significantly, and over time, these programs have become more inclusive and welcoming. Despite these efforts, we observe that some individuals with disabilities still face barriers in accessing services. To address this, we organize dedicated outreach camps specifically for persons with disabilities. These targeted interventions not only help us reach previously unreached individuals, but also build confidence within the community. Now, beneficiaries return independently for services after experiencing the accessibility and support firsthand. Additionally, to influence health-seeking behavior and stimulate demand, we developed culturally relevant campaigns using locally tailored approaches. These initiatives have proven effective in disseminating key messages, driving positive behavior change, and empowering individuals. Ultimately, this has led to enhanced health-seeking behavior and strengthened community ownership of inclusive eye health services. Next slide, please. Our approach was not limited to disability-specific activities. We also prioritized disability-inclusive strategies across all levels of our program. We collaborated closely with organizations of persons with disabilities for awareness raising, partner sensitization, and outreach camps. This collaboration significantly enhanced the inclusion and across all levels of our interventions. To strengthen the role of OPDs, we initiated capacity building activities focused on primary eye care referrals. This enabled the OPDs and their members to support their peers by connecting them with our partner eye care facilities and raising awareness about the importance of eye health. As a result, OPDs are now actively generating demand for eye care services within their communities. Moreover, we created opportunities for OPDs to raise their voice in key advocacy platforms. We facilitated their participation in national forums such as Citizens Platform for SDGs and the Disability Alliance on SDGs. Through these platforms, the OPDs have been able to advocate for inclusive eye health and promote self-advocacy at both community and policy levels. Very recently, they effectively contributed to the Bangladesh VNR Report 2025. Next slide. Disability disaggregated data has proven to be a powerful catalyst for driving inclusion in our program. To capture this data, we introduced the Washington Group questionnaire during the registration process at outreach camps. While this is still in the early stages, it makes a significant step towards understanding the status and needs of persons with disabilities in our service areas. This data allows us to make informed program adjustments that cater to diverse needs, supporting more effective monitoring and adaptive planning. It enables us to identify service gaps and guide evidence-based improvements, such as determining where to organize future outreach camps to reach the unreached populations. Beyond programming, this data also strengthen our policy advocacy force by generating credible, context-specific evidence. We are better equipped to influence inclusive policies and practice at various levels. Next slide. So we are beginning to see meaningful and measurable changes as a result of our inclusive eye health initiatives. The demand has been increased. There has been a noticeable rise in service utilization by persons with disabilities. In 23-24 alone, 520 individuals underwent eye screening and 38 received cataract surgeries through our inclusive outreach force. Significant improvements have been made in accessibility and service quality at our partner facilities. Currently, 3 base hospitals and their 21 community vision centers have adopted inclusive practices, and we have a target to scale up to 40 vision centers. They have the target to scale up to 40 vision centers by 2030. Eye screening services are being delivered through inclusive outreach camps. At present, 7 OPDs are actively engaged in referral process, helping to identify and link persons with disabilities to appropriate eye care services. Strong OPD-led platforms have emerged, amplifying the voices of persons with disabilities in national dialogues. Like I have already mentioned in Disability Alliance on SDGs, the Citizens Platform for SDGs, and the System Leadership Core Advisory Group, we have incorporated them, and each contributing to be sustained, systemic, and advocacy for inclusive eye. Next slide. So while we made progress, several challenges continue to hinder full inclusion. Like disability inclusion is often not prioritized in mainstream service delivery. This limits the allocations of attention and resource to ensure accessibility in eye care programs. The national budget for 2025 allocates only 0.48% specifically for persons with disabilities, highlighting a significant gap between the policy commitment and resource investment. Inconsistent and incomplete data remains a barrier. Like disability prevalence varies widely across sources from 1.48 persons from our national census to 5.7 persons from our national census of persons with disabilities and household income expenditure surveys, so making it difficult to plan effectively and target interventions accurately. As of 2025, only 3.6 million individuals are officially registered as persons with disabilities. This under-identification limits access to service and entitlement. And also a lack of trust in the system and limited awareness about accessible services among persons with disabilities continues to affect service uptake. Addressing social stigma and perception barriers is essential for long-term change. Next slide. So from our project experiences, the key takeaways are to achieve inclusive eye health change is necessary, not just for persons with disabilities, but also within the service providers, facilities, and mindset of healthcare seekers. True inclusion requires both strong commitment and dedicated resources. Without investment in infrastructure, training, and policy alignment, progress remains limited. Collaborating with organizations of persons with disabilities, that is the OPDs, has proven critical in expanding both our reach and effectiveness. Their lived experience and networks bring valuable insight and trust to our programs. Reliable data, evidence-based planning, and continuous dialogue with stakeholders are essential to drive sustainable system-level improvements in disability inclusion. Next slide. So I'd like to conclude with an inspiring quote from the visionary Dr. Fred Hollows, who once said, "The great challenges are not really personal challenges. How much can I do? The great challenges are what structures can I help set in place that will alter things." This quote resonates deeply with our mission. We aim to build a sustainable structure where the eye care needs of persons with disabilities are met with due significance, recognition, and priority, not as an exception, but as a standard. So thank you all.
Thank you, Badrul, and thank you to our three speakers, three projects presenting, also for keeping such excellent time. I didn't have to do that job of cutting you off. So that brings us to the end of the presentations, and now we'd like to open it up for discussion, for engagement, to bring your own experiences to share. So we also have online, and I'm looking on there, there's no questions yet, but is there anyone that would like to comment or share, or even from our panel? Yeah, go ahead. I have to give you the microphone. I think we've got some. Just so that online. I'll just be roaming around, so that's why I'm not on the screen. And just introduce yourself if you could.
Thank you. I'm Lucy Carter. I'm a social scientist at CSIRO. I just have a question for Carolyn and Wendy. I didn't, and it could be my misinterpretation, but was the Burnet Institute the main driver of the consultation process for the health research agenda?
I didn't really explain it before, but we already had a presence in Vanuatu supporting health research before. And because of that, because of the relationship and the partnership there, and also we have an MOU that includes specifically activities around health research strengthening. And then the request came because the Ministry of Health had already identified that they wanted to develop a health research agenda, but they didn't know. They haven't done it before, so it's the first one. So then we helped, but it was facilitation. Like essentially our role was facilitation, particularly for stage 1. It was really important for stage 2 to not actually even be in the room because we didn't want to influence voting at all, because then it can impose our own agendas, right? Yeah. So yeah, that was all Ministry of Health led for the second stage.
Okay, that's great. It's good to know. I wondered whether you had difficulty creating legitimacy and any challenges that you might have had to overcome that, but it sounded like you were approached as a trusted provider.
Well, that's how we've taken it. Hopefully that's the case, Wendy. And we haven't actually discussed this in this presentation, but we're also developing a climate change and health research agenda. The stage 1 consultations happened a few weeks ago, and it's a similar process there, but we actually have to kind of ramp up the explanation of the process, I guess, because it's stakeholders outside of health that are being consulted with. And yeah, the legitimacy it's really important because we know what we're doing and the steps, but we want to make sure that other people trust in that process and that it's a truly objective process that people can trust the final list.
Yeah. Thank you.
Thank you. We have another question back here.
Hello, my name is Riza from Indonesia. I have a question regarding the research of sexual and reproductive health from Vietnam. So after I watched your presentation, and I got also the idea that the adolescents and the mother have different perspectives. They have different view about the premarital sexual activity, and then about the marriage as well. And so I just want to know from your perspective how both of them, the adolescents and mother, perceive these topics. What is similarly and differently regarding this, and some from the quotes I also see that they just like whether they have interchangeably using the terms regarding about the sexual and the marriage, because I'm from Indonesia and sometimes we call kawin and nikah. Sometimes it's just like similar, but it's different. Some more into the sexual activity, but the other is about the marriage. So whether there is this fact or a blurred terminology regarding this as well there. And then secondly, it's about that you are being excited co-designing the sexual and reproductive health. So do I, because I'm trying to do this as well in my province. But when the adolescents and mother have different perspective on this, but not also that, it can be also related with the leader that have, maybe because I'm from Aceh, with Islamic way of government manage in our province as well. So how to see that this different view between the conservative and between religious perspective about this, and then when we want to make the intervention related with sexual and reproductive health, and then we try to make everyone support this, because sometimes even though we are trying with the start of what content that we should include, some people will say, no, this is not the content, but from the other side, yeah, this can be the content, something like that. So it's very difficult to run the intervention related to this. So maybe you have opinion about this. Thank you.
Thank you. I will try my best. You might have to remind me as we go of some of the points if I've missed them. But firstly, about the perspectives between the girls and their mothers. So we interviewed the dyad pairs, but we interviewed them separately. So we interviewed mothers first and then the adolescent girls. And that way we could hand on heart to the girls to say, we're not going to share your information with your mother. So it just gives them a little bit more trust in the process as well. But we asked the interview guides, they were pretty much the same. We were asking the same questions to the mothers and the girls, but with a slightly different bent on them. So in terms of the premarital sex and the importance of marriage, they were topics that were brought up by the girls and the mothers independently of each other. They both raised them as the most important issues to them. For the girls, it was, well, this is where the intergenerational flow of information is coming through and it connects the whole thing. So the girls were being told by their mothers and society at large, no sex before marriage, and don't get pregnant. Like, for God's sake, don't get pregnant. Yeah. And those messages were sort of morphing a little bit to, well, okay, look, if you have to have sex, okay, but just don't get pregnant. That seemed, in the end, at first it was very much no sex, and then it was, okay, maybe sex, but don't get pregnant. That seemed to be the major thing before marriage. But then for the mothers, that was their experience when they were young girls. Yeah? And for most, generally, they didn't have sex before marriage. And if they did and they got pregnant, they got married and then that was the end of the story. But now what we're seeing for the young girls, it is happening and they're not necessarily getting married, actually. Either they're having repeat abortions or grandmother looks after the child or she drops out of school and all of those repercussions that we know of. So the perspectives were the same, but everybody was coming at it from a different way, even though the poor girls were stuck in the middle because they knew what that social familial burden was on them about having sex before marriage and getting pregnant, but they really wanted to because things were changing for them. Globalisation, internationalisation in Vietnam is a big thing, their access to the internet. They're seeing that young people in other parts of the world and also in the urban areas in Vietnam are doing things differently now. And so their world was changing as well. Does that answer your question? Part of the question? Yeah. Okay.
Yeah. Yeah, the second part about content I'm really interested in, and maybe this also goes to your project as well, and also perhaps to Badrul as well, around the role of local actors. So in your case, it's around the contestations, like in Banda Aceh, living under Sharia law. There's a whole spectrum of ideas around sexuality and norms and acceptability, suitability. Of what content is. If you were to go to the next step, you're talking about, it's very exciting to be at the point where you can see these entry points, then how would you negotiate, local contestations of acceptability of sexuality and what, down to content. And I guess it goes also to your case around the contestations and how you navigate those. There's not just one local, right? There's not just one government. There's particular factions within even the Ministry of Health itself, right? So how do you navigate those contestations?
Okay, sure. So in Vietnam and also up in Takan district, they have adolescent and youth-friendly health services. It's a mandated part of their health system and their health policies. But the investment into the health system is not strong for these services, and the health workers aren't trained well enough either in these very particular skills that are necessary. And then in terms of comprehensive sexuality education, it is mandated in Vietnam as part of the curriculum, but it's not compulsory, and each school has a choice about if and how they deliver it. And what tends to happen with the sexuality education is it's sort of integrated because it has a very full curriculum, and it is less of a priority to maths and science and history and those sorts of things. So the school integrates it into biology. So the girls are saying, if I take biology, I might learn a little bit about HIV, a bit about puberty, that's about it. If you take the humanities stream up in high school, you won't learn about any of it at all. It's gone out of their curriculum. So, and much of it depends on the teacher as well. And some teachers know the importance of it and will just do what they can with their own resources. And other teachers just don't do anything about it at all. And so in terms of content, I was talking to my supervisors about this, what would you do? And, in terms of the limited resources in this area, we're thinking that one approach would be to look at what the prevailing priorities are in that particular area. And in this particular area, and in many actually across Vietnam, adolescent pregnancy is huge. And so maybe in high school particularly, it's focusing just on that bit of the curriculum. Okay, the curriculum I think has got like 120 sections to it or something. It's massive. And so just actually picking and choosing what is absolutely relevant for the adolescent population at this time in this area. Easier said than done, absolutely, I get that. But, where do you start? What do you do? I think we need to throw these ideas around. And equally with the public health campaigns, a lot of the girls, they said, we'd go out and we'd do it. We'd do it ourselves. And so they were sort of mobilising their own resources for that. And I guess it's very different in secular Vietnam than it is to where you were from as well. And in many ways, it's sensitive. The topics are sensitive, the conversation is sensitive, but they will have it. And they had it with me. And it was interesting as an outsider, some of them are much more comfortable talking to me about it than they would with anyone else. So there's those opportunities to get the conversation going with the right facilitation, with the right people. And look, I got permissions all the way from the top, all the way down the four governance levels in Vietnam to come and do this. And I had to share my interview the entire way. So everybody knew what my questions were, what we were doing. The transparency was remarkable, really, which is right. It's a good thing. So it had full support. I never would have gone up into those communities without it. They don't just let foreigners just wander around up in northern Vietnam willy-nilly and talk to ethnic minority communities. So we were open about that, and there was support. And that's why I said I would have loved to have gone straight into co-design, because when we met with the district and the provincial health authorities, they were going, well, is there more of a project coming? And I did this facilitated through Child Fund Vietnam, whom I used to work with. And so, of course, they were expecting, a project to come, and it broke my heart a million ways as a researcher to say, no, that's not what this is about, unfortunately. It may inform something through Child Fund, and those conversations are ongoing, but immediately I'd have to say that's not the case. But they were open to it. So that's where I think the contextual differences are so important around what you can do, and there's no answer from Vietnam that's going to serve you in that sense, other than experience and learning, I guess. Yeah. Does that answer your question? Lovely.
And I'll try and interpret the question for our project, and I take it to be about there's different voices and how do you listen to them. And I guess the way we've approached it is through like a systematic numerical approach, like so through the calculation of scores, but then talking about them and making sure that people were happy with the list and the ordering, etc. And there's not that we've actually had any requests to change the order, but the potential to discuss that through like a group format is there. And I think it also so in Vanuatu, for example, a good example of the different views on things is around vaccination, particularly around the HPV vaccine. So there's been fairly low uptake across the Pacific, including in Vanuatu. And I think, well, first of all, the top question that got the highest prioritisation score was on sexual and reproductive health, which was fascinating and exciting, and also around unintended pregnancies. I think that might have been number 2. And there's actually no research happening in that area. So hopefully through this agenda thing, people can say, oh, okay, so that's might be something that we can do that meets the, that fills the research gap in Vanuatu. But for the HPV vaccine, I think it was like number 7 or something. I can't remember overall from the 102 list of questions, which kind of shows that many people saw it as an issue, and everyone's vote was counted equally. And that's just how it was. And so that's what we present. So it was fairly subjective, I guess, in that approach. But it will be interesting now with the climate change and health research agenda because of the other stakeholders. And we haven't got to that point of presenting back yet. So we'll see what to do when we get there. Do you want to add to anything, Wendy?
Yeah.
That one around the vote, and you got so many votes. Are you able to disaggregate your votes by gender? Like did every woman vote for that and no men?
I can't remember
and
actually how
is that the mathematics work for that?
On the scoring that was done online, it doesn't collect on the gender, but it's on the area of specialty and the department within the Ministry of Health. So yeah, that's something that we didn't include it on the scoring part. But on the consultation one, on stage 1, it does have records of the different genders. Yeah.
And I'll just add one final thing there too, because of course there's going to be an inherent bias in the scores depending on who turns up to score. And we were really happy that I think the majority of people turned up, but not everyone. And there was opportunities for people to do the voting afterwards because the ministry selected key people from different units. Yeah, so to make sure that it was fair and everyone had an opportunity. And essentially some people did vote. And some of those people have complained about the process since. Fair enough, but it's fascinating watching the exchanges. But the response is, well, next time turn up. Because otherwise it won't go anywhere. But yeah, so in general, once people knew that it was a systematic numerical-based process to get that list, people were comfortable with that. For the stage 1, I reckon more females, and stage 2 equal, which is probably representative of the management. Leadership is probably more males. Is that fair to say? Yeah. Do you think that's right? Yeah.
This is Tain from Myanmar. I'm studying at the University of New South Wales for the Infectious Disease, Intelligence and Global Health. I'm really interested when you two presenters are talking about Myanmar. I had that names. My question is, I'm really interested in research, and I'm doing ongoing research with the Burnet Institute for the infectious disease surveillance. So I'm really interested in prioritizing the how do you carry out, with your rich experience, how do you prioritize in the context of Myanmar? We all know that since 2021, the democratic government overthrown and a lot of, nearly 5 years of conflicts is there. And a lot of, in terms of governance, a lot of players are, from ethnic minority to regional, and also like a lot of stakeholders are separated and they are governing the country at that stage. So if you want to approach that kind of research agenda, how do you, the first question is, how do you choose the which stakeholder you will select? Like for the military government, we don't even call military government, it is just a military regime. So, or do you choose the ethnic group who govern that areas, or how do you separate, how do you prioritize that one? And the second question is in terms of population, a lot, there are the vulnerability is like a competing each other. Like last 2 months ago in March, like 7.7 earthquake hits and more than 4,000 people lost their life. And do you choose that vulnerable groups, or do you choose like millions of people across border and they are and 9 million of people are stuck in the internally displaced within the country? Or do you choose that group? Or do you choose the cross-border people who are living in the Thai-Myanmar border? Nearly 60,000 people are around that Thai-Myanmar border. I worked for there before I came here. So how do you prioritize that population? This is my second question. And then the third question is like the kind of the topic. How do you choose the topic? Like when you choose the children, under 5 children, they haven't vaccinated yet for nearly 4 years. You would choose that topic, or when you choose the HIV or that kind of communicable disease or non-communicable disease, or what kind of things? And I would like to explore your rich and thick experience upon that my context. Yeah, thank you so much. I talk a lot.
Thank you for that. I'm going to just jump in because I worked for Burnet for 9 years before going to Child Fund and then doing this study. And in 2017, Burnet did do a research prioritisation work with the Ministry of Health in Myanmar under the Daw Aung San Suu Kyi's government at the time for tuberculosis. So in terms of health topics, it was a specific one. It wasn't lots of topics like Caroline and Wendy have done in Vanuatu, but it was specifically around TB. And so there is experience there, but with the civilian government, and so working with all the Ministry of Health authorities at many of the governance levels as well. And I can't remember if civil society were brought into that. Actually, I can't remember now. Suman Majunda did that. But there's experience there, and I'm sure there's records that could be shared in terms of process as well. But
again, the history of that, and Leah can probably talk to this, but so we have a DFAT-funded ANCP cooperation program, and we have been involved in Myanmar for years and years and years, Burnet as an NGO, and we've been the only NGO sometimes there. We have a very strong research capacity in our Myanmar team. They're very locally led, and they've developed, so over the years, Leah, when did you start that adolescent health program? 2015. So we've been working with monastic schools for years and years and years. So that's where we've developed the partnership and the trust. So the sexual and adolescent, the sort of life skills education project that Leah was leading for Burnet was very much engaging students, teachers, and parents. And we've been building that up. So we're now doing a mental health program with them as a result of all the trauma that they've had with the earthquakes and the coup and COVID. We pivoted towards COVID. So we've been doing lots of sustainability and economic generation with the communities in Magway. And again, where were they originally? Was it yeah, so we've... Oh, bless you. Oh, but we must reach out. Let's talk after this as well. Yeah? Yeah. Does that answer you? Thank you so much.
All right, I think I can try to answer two of the questions. First was around how to select stakeholders. And I think Leah was explaining the process, and I can't comment for Myanmar, I'm sorry. But just to note that it's much easier to select stakeholders in small Pacific Island countries than larger countries. So yes, so in Vanuatu and in some of the other small Pacific Island countries, you just know who the stakeholders are, and you make sure that you're covering all bases to make sure everyone has an opportunity to participate. So it is much easier in small countries. I think the next one was about how to decide what priorities are most important. Like, you've got different vulnerable groups. How do you decide one question is more important than the other? And it's so important, and that came up through our experience, because we had the full list, and it was really interesting from a quantitative research perspective. It's like, oh wow, that's where it is, but actually not useful. You should never pit groups against each other, because they're all important. They were all identified for a reason. So actually, you've got to take the numbers is good to start, but then you kind of got to take it out. And also, there's always going to be emerging priorities. So after the earthquake, there was an earthquake in Vanuatu as well, of course, and there's, frequent cyclones. So constantly you have to be thinking about what are the new and emerging topics. And that's come up for discussion too, about how regularly the list will be reviewed, because it is an intensive process. You probably couldn't do a full process every year, but I think it's yet to be determined, but I think we'll have a mini review probably towards the end of the year, and give people an opportunity. And hopefully some of those people that didn't turn up to voting will turn up and see the value in participating. And the other thing about making sure that everyone's voice is heard, I guess, is having those multiple lists, because everyone works in different areas. So if they have a list that they've highlighted the research topics that are gaps, and that's their list, that's really useful to different people in different units. So that has so far worked well. When did you want to?
I didn't cover everything. I think coming from a government perspective, so it's mostly for the priority, how we come up with a priority. To be honest, research in Vanuatu is something that is new to the Ministry of Health. So in 2019, they've established this Health Research Ethics Committee. And to be honest, we have no idea, there were no formal processes in place to guide us to review which research are priority for the Vanuatu Ministry of Health and for the government itself. And going to 2020, when we had the COVID-19, the borders were closed, and then there were discussion into we need to share findings, because we have all this data in place, but there's no capacity in place to guide us to look what the priorities are, what the issues, the gaps, even though we have all these interventions that were in place. So there were a first health research symposium that was conducted in 2021. Yeah, and from that there was initial discussions into the research priorities that was started at the time, and then it was moved forward and it was on hold for a bit, but then we continue to have all this research symposium in place, and then people come to understand the importance of data to drive decision and also for policy changes within the government system. And that's led to a draft of the agenda. And when we did the draft, it was we have no idea what the draft agenda should look like, and how can we get stakeholders for the Ministry of Health to participate and to come up with a refined list that would then guide us forward in moving to guide local and international research that would, end of the day, benefit the health system in country. So that's when we approach Caroline and the Burnet team if they can support us with that, and that's where we are. And mostly the priorities at the moment, it's like Caroline have mentioned, it's true unit specific that would score based on their specialty, and because they've provided service down to community levels, they know which specific populations. And yeah, with a country like Vanuatu with a 300,000 population, it's really easy to navigate around, but the higher the population, it becomes complex. So it's looking at different multiple approaches to go about with that. Yeah.
And what I like about this method of, getting consensus is essentially what you're doing is just how acceptable it is to everyone. Like, simplify it right down, turn it into numbers, and then, as you rightly point out, take the numbers out, because people can get stuck on numbers. But really, really interesting and adaptable and acceptable methods. I might bring our online presenter back in at this point, just to come back in, Badrul, about your work. Well, the recent DFAT disability strategy really puts an emphasis on recognising the role of OPDs. So we've been talking a little bit about dealing with contestation and local actors and different ideas. Would you be able to give us a sense of what sort of contestations are in this space around, particularly around, the role of OPDs, and how you've been able to navigate all of these actors, I suppose? Badrul, if you're there.
Yeah, thank you. So you correctly mentioned about the DFAT new strategy thing, like prioritizing the persons with disabilities and their representation. So it is very difficult. Organizations like us, we collaborate with other organizations, local organizations, and when we collaborate, we do some due diligence and other things. But for the OPDs, it is difficult for them to be so much organized, so much having good governance and other things. So it is very different, and we are flexible on that. And again, in the context of Bangladesh, the persons with disabilities, mostly they are deprived from education and health services and other things. So they are much shy and to raise their own voices. So it is very difficult. And Federal Foundation specifically work with IKEA, and it is another thing. So what we have done, we mapped the OPD's work in that project region. We talked with them. We done some orientations on them. We also provided them some support so that they have the primary knowledge, and they have their own members, and they have very good communication and I think impact over their members. So we utilize that networking, and the visibility of persons with disabilities in health facilities was very low, because sometimes they don't want to come to the facilities due to stigma and other things, and the context of culture, customs, and everything. And sometimes the accessibility is a barrier. So we utilize those OPDs. We capacitate them. We provided them information, where to go, how to go, and what are the incentives and benefits are provided by the government and our partner facilities. So then they became encouraged. They help their peers, their members, and we have a linkage. I already showed here that already 7 OPDs in our that region are working with us. They are they're referring to the patients to go to the facilities, and they know where to go and how they should claim their rights. Like, the government have some incentives for those patients, the fast track system and other things. So in this way, we are involving these OPDs so that they can raise their voice, and they can do some work for their community. And the other thing, it is very important, we provided them support to represent in different national platforms. This year, Bangladesh was one of the country, like they already submitted the voluntary national review in the UN. So before drafting that VNR, there was different sectors like education, health, and those things, and we supported them to represent their voice in those sectors. So, and in the VNR report, I have seen in the LNOB section, there are some reflections there. So it is a good thing that their voices are heard, and it is reflected in national policy level platforms. So now they are gaining those courageous inspirations, and it is making them confident to more visible in their context and in the national policy level as well.
Thank you, Badrul. Yeah, it's so useful for these OPDs to be using these international instruments to then reach national as well, right? Like it's sometimes have to leapfrog up to the international to be able to force an agenda nationally. Thank you.
Thank you.
We have a couple more minutes if anyone had any last thoughts or questions. If not, would you like some final words for what you've gained or what you would like to give to the group? Or
I guess I was, with my critical reflections and my questions that I offered, I was just wondering whether anyone had some experience to share about their work around how they're, thinking about social change, thinking about the inherent strengths of the populations and the people that you're working with, how you find that information out, how do you explore that, are we prioritising that? So I just wanted to hear people's experience, if there's any in the room. And if not, that's okay. You can get back to me later.
I think there's always that sense that, it's always contested. I did my work in Timor-Leste at the turn of independence and followed the youth of that time and watched them grow into middle age. It's always this idea. And, at the beginning, there was, some ongoing conflict at one point. And the youth were cast as problems, risks, and it's and that has sort of that conflict only lasted a little bit, but those ideas are just enduring, that youth are a danger, that they're risk, and it's that idea of contesting that with the voices. And centering always those voices of the youth, and that there's not one voice either. That they have competing ideas as well, and then how you bring that up to policymakers, I guess, is always an ongoing negotiation. I
will say that in Vietnam they have a lot of youth forums, a youth parliament. Their adolescent sexual and reproductive health policies are developing. They used to be quite disparate, but they're coming together now. But when it comes to implementing them, of course, it's the story everywhere. They're getting some tricky challenges, and there's certainly tensions there. But the rhetoric is there, absolutely. There's certainly a bit of a groundswell from the community around it as well. And everybody knows that, what happens in this generation influences the next generation as well. And so there's this, the Lancet Commission speaks a lot about this, the triple benefits, those sorts of things, or dividends around it. So there's a lot of recognition of that at the national level as well. And I think when we start seeing policies that are influenced by global agendas that don't quite match the social and cultural sort of dynamic and paradigm in the country, this is where the implementation is starting to get tricky. And so there's a lot of talk about adaptation of policies at the provincial and district level, but that's not really happening because the capacity is not there at the provincial level, whose responsibility it is to adapt. So this is the other part of the work I was doing, and I won't go into it now because that's a whole other story, about who should be doing that, how should that be done, and and who should be supporting that, the role of civil society, multilaterals. So the story goes on.
Okay, Badrul, any last words from you before we wrap up?
No, thank you. It was a learning session and cross-learning session, I think, and I have heard from other what are the things are going on in other part of the world. Vietnam is very much a similar context and culture. So So it is a good learning session. Thank you.
Thanks, Badrul. Well,
Thank
please,
you all who listen also. Thank you.
please join me in thanking our panel. Thank you for your rich contributions and the work that you do. Thank you.